Good afternoon, everyone. Thank you very much for joining us in this webinar in partnership with InnoMed. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation, and I'll be moderating this webinar on cancer inequalities between and within the EU member states. Thank you very much for joining us today. Europe's Beating Cancer Plan is one of the key pillars of the European Health Union project. For the successful implementation of the plan, cooperation must occur between the EU, member states, regional and local authorities, as well as with social partners and civil society organizations to bridge the large disparities in cancer prevention and access to cancer care between and within European countries. On December 9th, the European Parliament's Special Committee on Beating Cancer, Beca, approved their report, Strengthening Europe in the Fight Against Cancer. The report's focus is reducing inequalities, promoting cross-border cancer research and care, ensuring equitable access to therapies, including innovative therapies throughout the European Union, and promoting joint health technology assessments and joint procurements of diagnostic tools and medicines. It's a very ambitious program. To discuss the implementation of the Beca report, as well as the issue of cancer inequalities more broadly, I'm very pleased to be joined by an excellent group of speakers today. It's our honor and privilege to first have with us Tomislav Sokol, MEP for Croatia and also a member of MEPs Against Cancer. MEP Sokol, thank you very much for your participation today. How are you?
Thank you for inviting me.
It's our pleasure. We're also joined by Stefania Vallone, who from the Women Against Lung Cancer in Europe. Stefania, thank you very much. How are you?
I'm fine. Thank you very much for this invitation. It's a great opportunity.
It's a pleasure to see you, Stefania. We're also joined by Mark Boyd, the Senior Policy Associate from the Open Data Institute, ODI. Mark, thanks for coming. How are you?
Hey, everyone. Great to be here and to share in the panel.
We should also, hopefully, if everything works out, he's in transit, but he will try to join in. We also have MEP Negrascu from Romania. He'll be joining us. He's not with us yet, but hopefully he will. We also have the input of Stepko Pleština, an oncologist and clinical hospital, Zener Zagreb. Dr. Pleština, thank you very much for joining us, sir.
Hello, thank you for inviting me.
And last but not least, certainly our partner in this event from InnoMed, Marius Genta. Marius, please, as a co-sponsor of this webinar, can you say a few words about the need to reduce cancer inequality across Europe? Marius, thank you.
Hello, thank you so much, Dwayne. Indeed, we will have now a vital conversation on the transformation needed for the implementation of the Beating Cancer Plan in order to reduce inequalities. We will have now today the chance to discuss the additional factor that might influence the inequalities, like the behavior, and we have a lot of examples coming from the pandemic and vaccination campaign, the digital tools or cancer literacy. As well, I think we'll have a very good conversation on the EU role in the implementation of the Beating Cancer Plan, the willingness of the member states to work or to accept to be monitored by the European institution, and as well the intersection between the Beating Cancer Plan and Cancer Mission and the health technology assessment regulation already in place, and why not the pharma strategy for Europe. So we have a lot of initiatives. We have the Beating Cancer Plan in place, a very clear, I think, roadmap for that. And for lung cancer, just to say a few words about that, I think that lung cancer is the one who benefit more from the innovation in the last 10 years in terms of diagnosis, biomarkers, or comprehensive genomic profiling, a lot of targeted therapies, immunotherapies, and now the discussion around the need for a screening program. So I think we have a lot of topics to discuss today, and I'm happy to be with you today.
Thank you, Marius. It's quite an ambitious agenda, from diagnostics to access to aligning procedures. And MEP Sokol, obviously you are one of the people at the front of this who has to align what's happening in Brussels with the member state initiatives and the Beca report. MEP Sokol, the floor is yours. We look forward to hearing how you're going to do that.
Thank you very much. I think this is a very timely event that we are discussing this, because the Beca report, the report of the Beca Committee on Europe's Beating Cancer Plan, was voted on last week, and it was adopted in the committee, and we expect it to be in the next plenary, January or maybe in February at the latest, to be voted by the whole plenary of the European Parliament. And what is important is that this, even though this is not legislation, so Eurospeedy Cancer Plan and this report of the Parliament is not legislation per se, but it is a basis for all the legislative proposals that will come afterwards. But I will discuss this more in detail in a couple of minutes. So we know that inequalities are one of the biggest problems, and I think that's the biggest problem in healthcare in the European Union today, which European Union can address. We know that healthcare is primarily a national competence, but EU can provide added value to resolve problems which member states cannot resolve by themselves. And I think the main problem here is these inequalities, so unequal access to quality healthcare, different standards of treatment, different protocols, different financial possibilities, different equipment, problems with healthcare workforce personnel in some member states. All of these problems which result in different quality and different access to healthcare in the European Union. And if we look at health outcomes, we can see in the example of cancer that there are around 40% bigger chances of dying from cancer once you contracted it if you live in some countries of Eastern Europe than in some countries of the Western part of the European Union. So this is a big problem, and this is precisely one of the main challenges that we try to address in this report. So what we did, of course, the Eurospeedy Cancer Plan is a big achievement, and I think its biggest achievement is that it provides a systematic coverage of all stages which deal with battle against cancer. So it includes prevention, early detection, treatment, but also the afterlife of cancer survivors. And I think that is the main added value of the plan itself. Of course, with the plan, there are many problems. And I think the main problem with the plan is that it's not very balanced. So in some areas, especially prevention, there are very concrete measures, concrete legislative measures, proposals, initiatives which Commission has envisaged. But in the other areas like treatment, for instance, like addressing inequalities in the treatment standards across the European Union, they are just very broad, very vague measures which do not have real legal or financial power. So this is what we try to address within the Beca report, and the proof that we actually try to do our work very seriously is the fact that we table more than 1,500 amendments to the original report of our colleague Lenoir. So more than 1,500 amendments. I personally tabled 166 amendments. So some of which were just mine, individual, but some of them were joint amendments of my political group, the EPP. And this is also important because you know that EPP was the first political group which during the 2019 European elections put cancer as one of its main priorities in the next legislative term. And the result of this policy priority, putting policy priority on cancer, is the fact that now we have the European Cancer Plan and this report, and that we had Beca committee which came up with this report. So definitely, I think EPP as the largest political group in the parliament was in the forefront of this. Okay, so this was like an introduction. So to go more concretely to concrete provisions of the report and the plan. So firstly, the first area, the first big issue was prevention. And of course, you know that it is assumed that around 40% of cancers are preventable. And of course, there are different reasons which cause cancer, different outside reasons outside of one's body which cause cancer. But of course, the main cause of cancer is smoking. And we have a lot of data, a lot of studies on this. I'm not going to detail on that. So what we propose in our report is to be very strict towards tobacco. And we fully support what the Commission has proposed in the European Cancer Plan, and that is to increase the main taxes, excise duties on tobacco, in order to make tobacco less attractive for people to consume, especially for minors. And it's not just the question of taxation, but also any kind of, we propose that any kind of targeted advertising or kind of targeted targeting minors in terms of tobacco production must be clearly prohibited. What was the main point of contention here was about the so-called harm reduction or the alternatives like e-cigarettes, etc. There were big differences between the political groups on this, how to treat them, because the initial Commission proposal was to treat them equally as tobacco. So to treat e-cigarettes, vaping and things like that as harmful as if they were harmful as tobacco. So, but in the end, the committee came up with a more balanced approach on this. So we tried to find the kind of a middle way, and especially, but what we were very clear is that we want to prohibit any kind of flavors when you speak of these alternatives to cigarettes, any kind of flavors which are specifically targeting children, which make it more attractive for children to start consuming tobacco. And I think that the final version of the report is very good in this sense. Alcohol was also a topic. We also tried to find a balanced way. So the idea of the report is to really focus on heavy drinking, on heavy consumption of alcohol. We are aware of the fact that any consumption of alcohol is not very healthy, but the idea is to really focus on that what really matters the most, and that is heavy consumption of alcohol. That means more than 3 big glasses of wine or 6 glasses of beer a day. So this is the definition. So to focus on these heavy forms of drinking. Also, one very concrete measure in terms of prevention, and I'll go on then to early detection, is the HPV vaccination. So here we have a very concrete target, and that is that we want by 2030 to have 90% of targeted group. These are young girls by the age of 15 to be vaccinated against HPV. And what is also even more important here, actually, European Union plans to provide financial help to the member states to achieve this target. And because we think that this is very important, because HPV is the primary cause of several types of cancer. So a very concrete action in this area is something that we advocate. So that was more or less about prevention. There are also some other parts, but I cannot go into too much detail. But I think these were the main points about prevention. When I speak of early detection, we emphasize screening as very important, and I'm glad that my amendments, which specifically mention lung cancer screening, were also adopted by the committee. And I think that's also one of our topics for today. So what I proposed to also mention specifically screening against lung cancer is now part of the final report, and I think this is also very important. I'm very glad that this amendment of mine was accepted by other political groups. Okay, so this was early detection and treatment. Treatment is the area of the Europe's Beating Cancer Plan, which is the least concrete, I think, with the least amount of concrete and specific measures, which is probably logical, because any measures which relate to treatment also mean a very heavy investment on the European Union part. And we know that this is a big problem for the European Union. You are probably aware of the fact that the previous EU health budget for healthcare in the previous 7-year period, 2014 to 2020, was only at the level of 450 million euros. We managed to increase this by 12-fold, so by 12 times. So now we have the new EU for Health program, which amounts to 5.3 billion euros, which is, as I said, 12 times bigger than in the previous 7-year period. But this is definitely not enough. And especially this is not enough because a big chunk of that program will go for funding of the new agency, the new HERA, strengthening the ECDC, etc. So not a lot of this will be left to battling cancer. And this is the reason why I posed an amendment which was accepted, and that is to actually focus on cohesion policy as the main financial instrument of the EU to reduce inequalities in access to healthcare. Why cohesion policy? Because the aim of cohesion policy is to reduce general inequalities and differences between different parts of the European Union in terms of the level of development. And these differences in level of development are actually very precisely reflect also on health outcomes. So again, the so-called East-West divide. And this is why cohesion policy is very important, because it can provide a lot of investments into infrastructure, like equipment and things like that, but also into health workforce, into creating better working conditions for health personnel, for doctors, for nurses, etc., even paying for part of their studies or specializations and sub-specializations, like in my country, in Croatia. And these funds should be used much more actually to invest in healthcare than previously. Even though I have to say the previous 7-year period, around 25 billion euros were invested from cohesion policy into healthcare in least developed parts of the European Union. But what we want to do is not to strengthen that, and actually to have a clear set of health outcomes as benchmarks and indicators of how this money is spent. Meaning that we actually have much concrete analysis of the results of this healthcare spending in terms of better health outcomes, less mortality because of cancer, etc. So I think that this idea of cohesion policy as a tool to reduce inequalities is something very important. Also, one additional thing is what we proposed by the me as a member of DPP, which was also adopted, and that is better and simpler access to cross-border healthcare. Because we know that in many member states, especially smaller and less developed member states like Croatia, there are some health treatments which are just not available. Because especially for rare diseases where you have maybe 2 or 3 patients a year, and it is not economically feasible to maintain the whole hospital wards, many experts who deal with this, etc. So what we propose is that the current rules on accessing healthcare abroad in other member states, it becomes much simpler than it is now, to provide much more information for patients who are unaware of the possibilities to access healthcare abroad, and also to simplify the current prior authorization and reimbursement rules which exist in EU law today. Because currently, if you want to access healthcare abroad to be paid by your health insurance, you have 2 parallel sets of rules. European Union rules which regulate the same thing. One is the Cross-Border Healthcare Directive from 2011, and the other is Social Security Coordination Regulation from 2004. And these 2 systems are similar, but not completely the same. So what we want to do is to merge these 2 sets of rules, to have only one set of rules, which will be much simpler for the patients to understand, and which will be much more beneficial for the patients. For instance, currently patients who want to access healthcare abroad on basis of Cross-Border Healthcare Directive have to pay upfront for the cost of treatment and then ask for reimbursement afterwards. While if they use Social Security Coordination, they are treated the same as patients who are insured in the state of treatment, which means that they only have to pay the co-payment, which patients who are insured there have to pay. So what we want to do is to provide the patients with this maximum, the most beneficial way of covering their healthcare expenses, which means that they do not have to pay for anything out of their own pocket. And this is something that is also included there. And what we also were able to include in the report is the right to so-called second opinion. What that means, it means that, for instance, that if you want to access healthcare abroad, you need to get usually prior authorization from your own health insurance, and then the health insurance usually consults domestic experts, domestic doctors, who have to say that the treatments that they are providing themselves are not good enough, and that the patient, for this reason, has to go abroad. And of course, here you have a problem because not many doctors and experts would say this. So what we want to use European reference networks to use this network to actually get the second opinion from experts from other member states who will objectively say whether there is a need to access health treatment abroad, or you can get the best possible treatment in your home country. And what is also important, what would I also like to mention in the report, is also the fact that the European reference networks need to be strengthened by themselves and to provide additional funding for them, because currently we are again having problems in the discussion with the Commission about the level of funding of European reference networks. We in the Parliament believe that this needs to be strengthened, and the Commission has this problem of focusing on things like ECDC, HERA, etc. So we will try to put the pressure on the Commission to also find more money for European reference networks. And one last point on treatment, also the idea of the problem that currently that we have many expensive medicines, especially for rare diseases, in different member states with different prices. And in many cases, these expensive medicines cannot be afforded by the national health insurance systems, especially in the less developed countries with less resources, etc. So what we are proposing, and this is also part of the report, is to use joint procurement, similar as with vaccines, to actually to have this kind of joint procurement of medicines, especially for rare diseases, on European level. So what would this do? So it would provide a level playing field where everybody would pay the same, right? Not some unlike the current situation where some member states have to pay bigger price for medicine than other member states. And what is also important is, by doing this, if the European Union acts as a whole, then the European Union has a much stronger bargaining position when dealing with pharmaceutical industry, when making an agreement on the price of medicines, than if each individual member state does it by itself. So this kind of using this joint procurement to reduce prices of medicines, make it more transparent, and make it more and strengthen the principle of solidarity across the European Union is also something which is in our report on the Europe's BT cancer plan. So that was about treatment, and on the afterlife of cancer survivors. So there is one particular point that is very important, and that is the so-called right to be forgotten. So in many countries of the European Union, cancer survivors are facing discrimination after they survived cancer. For instance, that they have to pay much higher premiums for instance, health, for instance, life insurance and things like that. So what we want to do on the, and this is also part of the report, to actually use the current EU binding legal framework, which already exists. So we already have directives and regulations which regulate this area, to include this right to be forgotten within the European Union legal framework. Because currently some member states are guaranteeing the cancer survivors' right not to be discriminated when they sign, when they take out insurance and things like that, like France, Belgium, Netherlands, etc. But some member states do not have this kind of legislation. So what we are proposing is to adopt, is to change the current EU-wide legislation on insurance, on consumer credit, etc., to include this right to be forgotten for cancer patients, so that no cancer survivor in European Union is discriminated when making this kind of insurance contracts and things like that. So what the proposal is will probably be, so the idea is that after 5 or 10 years, probably 10 years after suffering from cancer, that the person cannot really be asked about medical history, about things like that when making this kind of insurance contracts. So this is also so in the Europe's Beating Cancer Plan, the Commission mentions this right, but it does not mention binding EU-wide legislation. So to resolve this problem by adopting binding EU-wide legislation, but this is why we in the Parliament in our report are proposing that this problem is resolved not by some kind of code of conduct, exchange of best practices, etc., but to actually adopt a clear, legally binding EU legislation, which will make this kind of a discrimination of cancer survivors part of history. So I think this was more or less what I wanted to say. So these are very concrete things where I believe that our report will provide an added value and actually improve on the content of Europe's Beating Cancer Plan. And after it's adopted in the plenary, we are waiting for the Commission to come up with concrete legislative proposals on how to achieve all of the things that I mentioned. So this is more or less what I wanted to say. Thank you very much, and I'm open to your questions and comments.
Thank you very much, MEP Sokol. Boy, there's a lot there we could go into. We could probably talk for 2 hours just on everything, the very ambitious plan you've gone through. Quickly, just to get into diagnostics, I think you're 100% correct that the initial European Commission Beating Cancer Plan was very good on incentives against prevention, but was not very good on treatment and diagnostics. And it's good to hear, and I've looked through the report, and there's a lot there. However, there's one thing about, particularly when we're talking about lung cancer, about diagnostic screening for MRI, and certainly Dr. Pristina can certainly address this too. I'm sure he will later. But there's another thing when we get into the more advanced genetic screening and some of the more expensive testing for segmentations. Are we looking at making sure we're getting the most advanced treatment available in some of the genetic screening technologies? Because something like lung cancer, which you mentioned specifically, is increasingly becoming a stratified treatment paradigm. Where ALK type mutations and other mutations for lung cancer. Is this envisioned in the Beca report?
Yes, we definitely. I think when we speak of advanced treatments, so the whole idea is to actually facilitate it as much as possible. So we also provide, and we want a much stronger commitment in terms of funding of research on EU level. Even though I have to say, one big achievement, which was also partly caused by the Parliament, is the fact that beating cancer has become one of the priority missions of the Horizon. And I think this is something which is very, very important, because this opens up the possibilities of much higher funding in terms of cancer research than it is envisaged today. So I think that when we mention cancer research and advanced therapies, this is something that is definitely strongly highlighted in the report. That's one part. And the other part is what I already mentioned about facilitating access to advanced therapies when they are not available in your home country. And this is very important, that patients become aware of these possibilities which exist in some other member states, and that the whole system is made for them to make it easier for them to access this healthcare. So, for instance, that they have all the information provided in their own language, that they do not have to pay upfront and ask for reimbursement, that the prior authorization requests are handled in a short period of time. So, because in many cases you don't have time to wait for 2 or 3 months, etc. But one thing which we cannot change is the provision in all of the relevant EU legislation that only those treatments which are covered by domestic legislation are also need to be provided when going abroad to get treatment, which means that national healthcare systems do not have an obligation to cover experimental treatments abroad. Because in no country, because in countries of the EU, in the member states, legislation does not cover experimental treatments. So it's not part of the social health insurance package, which means that if something is an experimental treatment, in most cases, national authorities will not fund this kind of treatment, and the idea is the so-called priority setting, so that these funds, which to pay for this kind of an experimental treatment, which is not proven at this stage, can better be used to finance something else, because the resources that we have at our disposal are not infinite, right? So this limitation in terms of accessing new and innovative treatments will remain in new legislation. But what is important is, if a treatment is not proven in your own country, but it has already become a standard in Germany, let's say, then you cannot refuse the authorization to cover this kind of treatments in Germany just because this treatment is not available in your own home country under your own legislation. And this was said by the European Court of Justice already, I think, 18 or 20 years ago. But now this is also part of EU legislation. But we need to make sure that this is also implemented in practice, so that we do not look at only one individual member state when we look at where the best possible treatment for a patient is available, but that we look at the European Union as a whole. So this is kind of the approach that we are taking.
And will then the revision have enough teeth to implement that? Because yes, it was passed 18 years ago that you could not have these dispersions of care, but they have been occurring. Are we going to try and get teeth into this to make sure that the cross-border care can be delivered? I mean, is that possible?
Yes, we are putting the pressure on the Commission to come up with the revision of current legislation for cross-border healthcare. There will be also other things which Commission will propose in the next year or so. Also, there is the probably most important piece of EU legislation which will come out in the beginning of next year is about EU health data space. And this is also very important because, for instance, if you want to conduct cross-border clinical trials or cross-border research, you have a problem of different protocols, different rules of how to use data, different interpretations of the GDPR, for instance. And this is something that you're also mentioning in our report. So that this is a big problem, and that this regulation on the EU health data space should make this data interoperable between different member states, and should create common protocols which can then be used to share data between different healthcare systems. And this is the necessary prerequisite if we want to conduct cross-border clinical trials, health research, I think scientific research and things like that, which is also very important for smaller countries like Croatia, which obviously do not have, which are too small to be part of to be the focus of big clinical trials. So we need to be part of some kind of a cross-border collaboration. And if we want to be part of cross-border collaboration, then we need these common rules on the use of data as well.
Fully agree. Thank you, MEP Sokol. I understand you have to go. Thank you very much for your input, and it's been great having you with us. I'm sure we'll get back to you with some questions that have come up. I see that MEP Negrescu is with us as well.
Yes,
hello,
and
sir.
I think it's the right moment to introduce Victor Negrescu, who is the member of the European Parliament, but when was in charge with the Minister of European Affairs in Romania, support us a lot on the cancer topic, trying to prioritize cancer as a priority for the Romanian presidency of the EU Council 2 years ago. So Victor Negrescu is in this area of cancer for already for many years. And thank you so much for being with us today, MEP Negrescu. The floor is yours.
Thank you so much for the invitation. It's nice to see you all, and of course, listen to the previous intervention. I want to say a warm hello also to Marius, who is doing a great job in Romania, not only in Romania, in speaking about how to deal with cancer and what are the solutions, and how innovation technologies can be helpful, of course, in reducing the gaps and coming up again with proper solutions to an adequate fight against cancer. And of course, in this regard, you know very well, you already mentioned before, we have the European plan, which is, in our opinion, a good landscape to properly address this important issue in an adequate way at European level. And of course, along those lines mentioned in the European plan, we have this clear strategy focused on new technologies and digitalization that, with proper investment, with adequate resources, and of course, synergies at European level, can help us, of course, work more, especially on the issue of prevention, but also on the issue of treatment of patients with cancers. And of course, in order to do that, we believe that the recovery plan offers us the possibility also to offer adequate resources, adequate investment to, again, invest more in new technologies. Because if we coordinate at European level when doing such investment, first of all, we can become more efficient in that type of investment, but also in the same time, make sure that we are moving at the same pace and dealing with the problem that everyone is facing when it comes to dealing with this disease. And of course, there are clear solutions. Data is a key element. Collecting data, using data in a proper way, in a secure way, in a safe way for patients is one of those key elements that need to be dealt with. But of course, it's not only related to that. We have a lot of issues regarding, again, specific research in the field, issues regarding, again, medical technologies and how we are using them, and how we, again, make sure that all those technologies are compatible with each other, but also compatible at European level. Because if we are moving together in the same direction, probably we'll find better solution in tackling the challenges. And I think when moving together, one of the key issues, and here I'm speaking in my capacity as Vice Chair of the Culture and Education Committee in the European Parliament, I think one of the key issues that we often mention, and I often mention here in the European Parliament, is this issue of education regarding health, but also cancer literacy, which in my opinion is something that needs to be highlighted more, because it's really important, again, to understand, again, the risk to which we are exposed, and at the same time understand in some cases why it is important to be tested, and again, what are the recommendations of experts in the field when it comes to prevention. In the same time, when we speak about education, we also speak about highly skilled education for people working in the field, for medical staff especially. And in order to do that, we need, again, to invest more, because if you look at the curriculums for medical schools across Europe, sometimes there are differences of approaches. And sometimes, we speak about technologies in some countries and people are not testing those technologies. So they want to enter hospitals afterwards, but the assistants or the doctors, but mainly, of course, the medical staff, doesn't know the technology that they are supposed to use. So they need, of course, every time to get to know the new technologies. So we need, of course, lifelong learning, a lot of investment in that. And of course, in making sure everyone is fully updated on what can be done, on how to work actively when using new technologies, on how to use effectively, again, the new tools. So all of that needs to be done. And of course, if we decide, again, to have an action plan, and of course, we decide to have an action plan on this issue, it's important, again, to make sure that we are tackling, like I said before, again, potential differences, potential gaps, reducing them as best as possible. And I think in this regard, the recovery plan, or Horizon funds, Digital Europe program, the cohesion funds, all of those financial instruments should also try to address, to a certain extent, this need of having, let's say, an integrated approach when it comes to dealing with cancer or fighting against cancer. So you can count, of course, on my full support here in the European Parliament, and of course, in raising the issue, in underlining some of the key elements that experts want to point out in the discussion, but also in being very active in speaking about cancer literacy, which in my opinion is also a significant element of any concrete and effective fight against cancer. Thank you so much for having me here, and yeah, I wish you the best of luck for the continuation of your discussion.
Thank you very much, MEP Negrescu. Just quickly before you go, obviously, a lot of the things you mentioned require data usage, data access. If we look at Germany, a lot of the medical records are faxed still. They don't even have EHRs. A lot of this comes down to GDPR. I'm sure Mark Boyd at the Open Data Institute will address this as we get to him. But quickly, do we think that the GDPR right now is fit for purpose with a lot of the expectations you're setting, particularly in your intervention here? Do we have enough resources available with regards to being able to share data right now, or have we over legislated on some respects?
I think we need to offer clarification, especially when it comes to medical data. I think the GDPR regulation implies, of course, some decisions also to be made at European level and in coordination between the agencies responsible for data protection. And I know some data protection agency at national level also made specific requests to the European body to come up with concrete arguments and again solutions on very clear and specific elements. I think we need again to have this open discussion in a transparent way and involve, of course, medical experts, involve the European Parliament, involve relevant stakeholders in being very clear. Because again, when we refer, and I'm not an expert in the field, but this is what I know very concretely is that we need data to offer again personalized medical solutions, and data is key for the future. Unfortunately, you say data are collected in Germany, maybe not to a large extent. Data are collected also in Romania, but again, which type of data? To which degree, again, our system of collection of data are compatible between each other? This is also a significant element. So I think in this regard, again, it's not about avoiding regulation. This is about adapting regulation, again, to each specific field, especially to the medical field, use the potential of data in an adequate way, while in the same time having guarantees that will, of course, ensure again that everyone has a control over his or she's own data. And I think this is possible. I think there are solutions, not only in Europe but elsewhere. But I think the European body has to move actively. And again, I'm going to be very frank. I'm not the only one to say it. I think at European level, again, the body should be more available in discussing, in opening the discussion, because the regulation is a set of recommendations, clear lines. But again, it's up to us to adapt, to discuss, and to put the issues on the table, not ignore them and just say, it's written there like this, we cannot change them. The world changes. So I think it's very important, again, to adapt to the changes and to the needs.
Thank you very much, MEP Negrescu. I'm sure you may have other places to go. If you can stay, it'd be great. But and I'm sure Mark is chomping at the bit to answer that. But unfortunately, we do need to move on quickly. And Mark, I'll be getting to you. I do think it'd be great to get the patient voice now and to hear what's going on with regards to how we're going to implement this and how the patients can get more involved. So, Stefania, I understand you have a presentation, and the floor is yours. Thank you.
Yeah. Thank you. So good afternoon to everyone again. I represent Women Against Lung Cancer in Europe, that is a lung cancer patient organization based in Italy. And actually, we work in this field since 2006 in order to support people with lung cancer and their families. I think today is a great opportunity to be here to discuss with you also how we could really bring tangible outcomes and benefits for all the people that in Europe still live with cancer, not only with lung cancer, because cancer is still a real threat for millions of people who are diagnosed with cancer and sometimes even die for this. And even if scientific advances in the last 15 years have improved the option to early detection and also to fight against cancer, especially with the advent of personalized medicine that has marked a new era in the treatment of cancer, but especially in the era in the cancer, in lung cancer, because we know that unfortunately it's still considered a very big killer worldwide. And in lung cancer, fortunately, the assessment of tumoral molecular profiling now has become really a key aspect for the therapeutic decision-making process, and data confirms that molecular diagnostics and innovative treatment can really offer not only important benefits and clinical outcomes to patients, but also healthcare reducing cost and more efficiencies for the healthcare system. But even those is necessary to make them available and reimbursed in every country, because unfortunately there is a strong evidence that access is still unequal across countries, not only across European countries, but even in the same country. So people with cancer cannot wait for that. They deserve to have the same opportunity to be cured, to be treated, to live longer, to live with the best quality of life that's possible. So we're talking about a European beating cancer plan that is important in order to address all these challenges, but is also important to ensure that in implementation will be now. So it's important to turn the plan into reality, to turn it in something that is really concretely tangible. So we know that actually the flagship of the 6 of this plan is aiming to improving the implementation of next generation sequencing in order to increase also the access to diagnostics and for people with cancer. But unfortunately, there are a lot of barriers that delay and sometimes even prevent the adoption of next generation sequencing comprehensive biomarker testing. Firstly, cost. There are huge costs for this kind of methodology, and in many countries, unfortunately, these costs are not reimbursed, not fully reimbursed. There are disparities also in terms of healthcare resources. So actually, there are differences in infrastructures between centers, and there are not enough laboratories for performing comprehensive biomarker testing. Also, the level is not always the same. And for this reason, tests sometimes really take not only days, but even weeks. And this obviously prevents sometimes and delay the access of people to receive the right treatment at the right moment. But also the limited, sometimes the limited or different staff expertise can delay this methodology. There are another big problem that we can observe in many countries is also related with stakeholders' awareness and education gaps. So policymakers, payers, healthcare professionals, patients, wider public, they really still have a poor understanding and awareness about the benefit that comprehensive biomarker testing can offer to people with cancer. And for decision makers, this can generate maybe a poor allocation of resources, not only human resources, but also financial resources. And also in healthcare professionals, sometimes the understanding and the awareness vary depending on the medical community. So it's not equal everywhere. And also with patients, we have the same problem because there is a limited understanding and awareness among patients. So sometimes they don't ask a clinician to receive this testing because they're not aware about that. And these discrepancies that I'm talking about are confirmed also by data that were collected by Lung Cancer Europe in 2019, the end of 2019, through a quantitative and qualitative surveys that we did across Europe with healthcare professionals, pharma industries, researchers, to understand what is the situation in terms of access to molecular testing. And as you can see, the results really shows that there is a big differences, especially between Western and Eastern Europe. And if we move also to the access to innovative treatment, the results is the same. In the Eastern Europe, there were a lot of countries that didn't have the access and the reimbursed of different drugs that were already approved by EMA. For example, in Latvia, the 68% of drugs already indicated and approved by EMA were not reimbursed. So determinate also a different level of opportunity for patients to receive the right treatment and also to have a great opportunity to prolong their life and to live with a high quality of life. In terms of access to clinical trials, the situation is the same. As you can see, in 2019, there were 421 clinical trials available in Europe, but the most were available in the western part of Europe. So in Spain, Italy, and Germany, with the rest of Europe with very, very few possibilities. So here I just try to summarize some proposals to improve access and reduce disparities, and I want to share with you what I put it here. Surely to have more investment and more funds allocated and dedicated to personalized medicine will help to receive this opportunity for more people across Europe. It's important to invest a lot in increasing the awareness campaigns and increasing the education and the understanding of a lot of stakeholders, not only patients, but also healthcare providers, also policymakers. So I believe that patients and professional organizations can really play an important role, maybe, in developing material and be supporting and partner also with the EU Commission, and also increasing funds in order to build the infrastructure for performing the comprehensive biomarker testing, because it's essential not only to have infrastructure, but also the right equipment, and also to facilitate the access, but also to facilitate the communication and the collaboration between centers. So it's important to increase the number of labs, the level of labs, but also to increase the level of IT system, so that enable also the clinician to share data, to communicate to each other, and also to learn from data from the other centers. The implementation of molecular tumor boards are really important, especially in a complex disease like lung cancer, where it's really, really difficult to have a right diagnosis, because now we are talking not about one disease anymore, but about different rare diseases. So it's really important to have a specific molecular tumor board to provide a quick and accurate diagnosis in order to define the strategic plan to treat people, and also to develop accredited center of excellence in any specific disease. Then also develop the expanded access, the compassionate access programs in order to promote the access to drugs, to clinical trials for people in a place where, for example, drugs are not yet approved and reimbursed. And obviously also to develop and try to harmonize the guidelines across Europe. This is just a best practice I would like to share with you. Is a European program that we designed and we are realizing in Italy. Is a program completely developed by Women Against Lung Cancer Europe, obviously with the private funds from pharma companies. That is endorsed also by the IACLC, that is the International Association of Study on Lung Cancer. This program is trying to offer a very practical program to try to reduce the disparities that people actually have to face in the different European countries, especially in the western part of Europe. With this program, we try to increase the number of molecular screening and to facilitate also the accrual of people in different clinical trials, not only in the country where people live, but eventually also in other countries. And we provide also logistical and financially support for people who, after performing the molecular screening profiling, they result to be the right candidate for receiving a treatment. This program is available. We started at the end of 2020, where we already received 250 samples from different parts of Europe, from Slovenia, from Croatia, from Greece, so not only for Italy, and obviously is available to any other country in Europe who want to be part of this network. This is the platform where you can find more information about and to apply to be member of APROPA. So just to conclude, and I think that as a patient representative, I encourage all of you to work together to try to ensure prompt patient access, not only to diagnostics, but also to innovative treatments. And I think that it's really necessary to have a EU-wide approach in collaboration if we want that the flagship 6 could have a success. And without innovation, there is not future, but innovation could be not innovation if people don't have access to treatment and diagnostics. So anyone should have the same opportunities.
Thank you very much, Stefani. I'd like to come back to you, but we're running a little long, so I will go pass over to Mark now and get him to interject on some of the comments we've had from our MEPs. Mark, thank you. The floor is yours. Thank you.
Hi, everyone. It's great to be here. My name is Mark Boyd. I use the pronouns he and him. I'm just sharing my screen. I've got a really quick presentation to walk you through. So this is about for Roche and for Open Data Institute, we did a study of the use of secondary use of health data across Europe. And now I want to look at the implications of that for addressing health inequalities in cancer care. Just very quickly about me, I've helped establish patient representative organisations in Australia. I've worked on health inequalities at the population level for city governments and helped them map dashboards to identify that. I've led some European Commission work on how do you exchange data between digital governments. And then for World Health Organization, I did some research on data governance models, which influences how health data is shared. So for secondary use of health data, under the GDPR, it was great to hear MEP Sokol talk about the different interpretations of the GDPR and the use of data. That under the GDPR, it actually just says secondary use of data is any use that's not the primary purpose use. So we've given it a bit more flavor by actually explaining, okay, in health, what does that mean? It's the use of aggregated or population-wide data collected from things like electronic health records, wearables technologies, platforms like the one Ms. Valloni just described, the eProper platform, clinical trials, all the rest, using that then to improve personalized healthcare, medicines development, monitor safety, and do research and policy making. So it's hugely important. And in fact, if you look at a lot of the current European-wide health policies, you cannot achieve a lot of the goals unless you're making use of health data for other than the primary purpose that was extended. I had a quick look at the European Beating Cancer plan, and here all of the ones in green, when you look at the different strategies in that plan, you need to use health data for secondary purposes in order to be able to achieve the goals laid out in that plan. And there I can see, of course, the typo is going to sneak in, but you can see that it's essentially important in order to deliver on things like improved diagnosis and screening, you need that pool of data to draw on, for example. Okay, but if you're going to build an ecosystem where you're making use of secondary use of health data, it's got to be trusted by people to share their data, clinicians to use that data and to enable that sharing within their setting, research to not want to hoard the data for their own research funding opportunities in the future, for private companies to be willing to share with their partners and so on. So at a country level, you need to have the legal frameworks and accountability in place. For stakeholders, you need to have good data governance processes that enable that sharing. And at a community level, you need that trust and the awareness of what the benefits of sharing the health data are. So to address inequalities, we need then multi-stakeholder collaboration, so a whole range of players involved. Very much important to have the patients and the carers involved in sharing that data as well. And then you also need to understand where the benefits are from that secondary use of health data. So for example, for optimizing health systems, we've heard a few today where data can help strategically direct services to those with the greatest health burden. So it can be used to ensure that you're allocating resources to address health inequalities. And there's some research there. I'll share my slides afterwards because there's some examples of where that's happened and resources have been allocated to those most in need. When you're looking at health inequalities between countries, you also need that data. There was some great work from Ms. Valloni shared there about the EMA remunerations and the clinical trials and using health data to optimize health systems for Europe as a whole really identifies them where there's those inequalities. So also for improving the patient journey and enabling personalized healthcare, what is needed there is data needs to be available at a disaggregated level. You need to be able to see that health data impacts by gender, sex, sexual, race and ethnicity, socioeconomic status. And if you're able to see those, then you're able to identify who's missing out on treatment, access and opportunities, and able to direct, again, not only just direct resources, which is optimizing, but also involve patients or be able to steer particular solutions towards those populations that aren't showing up in your data. And then we've seen again that we've just seen a great example of data being able to encourage that patient-public participation. It seems like it's been a crucial step in Ms. Valloni's work to build that awareness and support, but also we've seen some of the links here for research show that when patients are involved in chronic disease management, then they're more likely to have those conversations with their doctors and with their healthcare team, and then be able to improve their health. They're better at sharing their episodes of care as they go, because they've been involved in digital tools that help track that. And then of course, expanding innovation. There's some countries like Finland, Austria, Sweden, who are actually trying to open up the health data use in order to encourage new health tech to be based in their countries. And so it's really, there's an opportunity right now to be able to get this right around how health data is going to be shared, so that you're able to then spur new innovation within country and open up new industries locally. So just finally, from the research we've done, so again, I'll give the slide deck, it's got the links to the research, but the biggest problem, as we heard from MEP Negrescu as well, is that one of the challenges is that the GDPR ensures the protection of control over data, but it gets misinterpreted at the European level, or it's different within each country. Even if that was solved today, there will be a ton of other work that individual agencies could get on with and do, making sure that their data sets are disaggregated so that you can look at the health inequalities focus, being able to anonymize and aggregate your data so that it's protected and is available for interpretation without the risk of identifying individuals, creating codes of conduct and data sharing agreements between different stakeholders, so that that's prepared, so that as then the European health data space and other work continues to be able to open up that data sharing, that the local stakeholders already have the systems in place. So now that they've got the legal interpretation clear, that can start happening. And so, you know, clear definitions of health models so that there's that interoperability happening and so on. So there is a whole bunch of work that could be done, even by the people who are listening in today, to get the sort of ship in order, so that as the opportunities for secondary use of health data expand, then your data governance systems are ready to take advantage of that. So that's my slide deck. I was keen to not push over time and give a bit of time for questions for the whole panel.
Thank you very much, Mark. One of the problems, and I'd like to obviously get Dr. Pleshtina in now. Thank you very much for being here. One of the problems we're seeing, Mark, as you're pointing out, and as well as Stefania pointed out, we have a reliance and a need to have access to good, high quality data. GDPR is a barrier, but often as well, the practitioners themselves are unwilling to share data because this is a point of bureaucratic and political power within an institution. And the regulation, I don't want to say serves as a good cover, but it certainly provides an opportunity to not engage in data sharing. Dr. Pleshtina, from your perspective, what do we need to do to get the data shared practically so practitioners such as yourself can get best practices and get best use cases out there? Where are we at with that?
So it's quite simple. Data share should be the obligation. That's the point. So it's very well known that in the southern and eastern part of the Europe, mortality is higher than expected. On the contrary, the incidence of malignancies are higher in western and northern part of Europe. So if you compare the chance for the patient with colorectal cancer in Croatia and in Denmark, is quite clear that the chance in Croatia is less than 50% compared with Denmark. Why? So there are several reasons for this, among which the most important is probably the fact that malignant diseases in regions with higher mortality are detected at the advanced stage, but we do not have proper data about that. Even in Croatia, where we have for a few decades cancer registry, but not a clinical database, just epidemiological. The results of the treatment are expected to be worse in the parts with advanced disease at the moment of diagnosis. So therefore, we need to work on primary prevention programs, as said before, and early detection of tumors, of course, with a proper response from the target population. At the moment, we have about 20% of citizens recalling our screening program in colorectal cancer. However, there will always be patients or those who will need quality surgical treatment, systemic treatment, or radiotherapy. It's important to clearly define the oncology network to identify high volume oncology institutions capable to provide quality, high quality and comprehensive care. So I think the first step, it will be very good and necessary to set minimum accreditation standards at EU level and clearly prescribe what the patient will receive and within what period. I agree that GDPR be differently interpreted within countries, but if we have the EU regulative, then it shouldn't be the problem. So clinical database, oncology database, we have on an institutional level, but not at the national level. Neither we can compare our results with other institutions. Early, we talk about cooperation between institutions, between countries, but are we ready to share the data? How our patient know where is better? I can say that in my institution, University Hospital Zagreb, I don't know, a woman with metastatic breast cancer survived 12 years. There is no data about that.
Now, getting to that point about benchmarking, they tried this in the UK, and it was the doctors themselves that pushed back really hard. They didn't like the accountability. Mark, getting to you, how do we get around that? I mean, Dr. Plashtina is bringing up a lot of really good points. Obviously, there's a lot of frustration there from the practitioner side. If we're trying to improve outcomes and we're setting up all these dashboards, what do we need to do practically to make this happen?
Yeah, I think so. I think one of them is we've got to keep coming back to those benefits that we described or we identified that come from the health data. And I don't think that they're clearly understood or that they're not used often enough in how we're talking about the reasons for opening up data. So the various advocates, when we're working with different stakeholders, it's to ensure that there's the understanding, because a lot of that pushback comes from fear that it's going to be about malpractice. You know, it's fears of, so there's those sorts of fears from doctors. Then for hospitals and especially research institution hospitals, it's the fear that they're going to miss out on funding if they don't hoard their own data and put it in their own standard models that only work with their other sort of data and aren't interoperable. So there's some of those reasonings. You do need incentives in the system as well. So a bit like how we heard from MEP Sokol with increased taxes for cigarettes, we also need rebates for doctors who are completing their electronic health records properly, who are working with their patients to inform them about their consent opportunities if they share their data for new treatments. So we need some of the systems to change there. Switzerland's got a good example where any research institution that's funded by the government now has to adapt one of their current data sets interoperable standard so that it can be shared more widely. So it reduces that competitive culture in the past. But because a lot of them have been set up with that, and we've got to change those cultures.
Thank you, Mark. Dr. Plashtina, again, do you have access, if let's say you wanted to call for an ALKA type BRCA1 screening for lung cancer, can you do that quickly right now into the current environment you operate in?
Lung cancer screening program is something new in Croatia. It lasts about 1 year with, I think, very good results because the platform is quite different than we have with breast cancer, colorectal cancer, and cervical cancer. So it's, I think the crucial moment is that GPs are involved. So GPs are crucial to select the patients, to say them go for the screening. So I think the results of lung cancer screening will be better than we do have with colorectal cancer. So it's, as I said before, about 20% of invited citizens reply to the program. That's and a little bit more than 60% of a targeted population for the breast cancer screening program. So, but give me a chance to say something about new paradigm or personalized healthcare or personalized medicine. So that is the chance for us because we have a very important and interesting program implementing genomic testing into everyday practice. So earlier, you asked me about data. Earlier, data generated from phase 3 prospective randomized strongly controlled studies were needed for approval and for routine practice, but they are slow and very expensive. So if we can share data, I'm talking from the position of Croatia. We have just 4 million inhabitants. We could not count with our results. We need world results.
Right.
But to have in a short time proper results for everyday clinical practice. So genomic insights are driving this transformation, especially in oncology, where at the moment more than 200 clinically very relevant genomic biomarkers have been yet identified across diverse cancer types. So making each patient a cancer unique. So that these biomarkers are changing cancer care from the conventional organ-based approach to tumor agnostic, to one that is increasingly based on genomics, especially in advanced stages. So these biomarkers can distinguish treatment responders from non-responders and avoid adverse events. So this shift towards personalized health care has potential not only to deliver better outcomes for the patients, but also to reduce health spending on ineffective care. So that's its interest not only for the patient or health professionals, but also to healthcare providers, for insurance companies. So that is very important to say.
Thank you, Dr. Plashtina. Marius, I want to come to you. So we've just heard about some of the gaps to implement personalized medicine. We've heard this from Stefania, from Mark, now from Dr. Plashtina. What do you need to do? Because you're working at the coalface in Eastern Europe. I mean, how big are the gaps and what do we need to get to clear this up?
Yes, I think Stefania's presentation actually shows us that the highest is the complexity. When it comes to cancer, the higher is the risk to increase the inequalities. And your table on biomarkers, the use of comprehensive genomic profiling, molecular tumor boards, all of these type of innovations, all linked with the data, actually. All of these actually are a major factor for the increase of the inequalities. And we should be, very careful when we have in mind to implement this. And I have a short comment before on the data, because I think it's as well a matter of attitude and perception coming from the medical professionals, because I'm not sure I'm a medical doctor, so I'm not sure we perceive the right value of the data, especially in the cancer, and somehow we should be able to identify ways. And I'm linking this with what MEP Negrescu said, related to the need for new curricula and education for healthcare professionals. I'm the chair of the IC Permed Curriculum and Education Working Program, and we are actually scanning for personalized medicine programs across Europe. And I can say that are only 2 countries who provide master degree on personalized medicine. So we are discussing about, comprehensive genomic profiling and genomics and data and all type of innovation around the personalized medicine. But when it comes to real education, and Mr. Negrescu said very well that you can have in your country different types of technologies, new technologies, AI-based machine learning, and so on and so forth. But you don't have the proper training, and you are not able to use this, or at least to accept a diagnostic support tool. What should be done? I think we have actually 5 recommendations, and we discussed this with the European Commission last year, part of the consultation around the Beating Cancer Plan. The number 1 is to have a multi-stakeholder approach. In other words, to use all the institutions, people that could help, and especially the NGOs. And I was very happy 2 days ago to see that the State of the Health in Romania actually quoted Center for Innovation in Medicine, our group, in terms of recommendation on how to implement Beating Cancer Plan in our country in order to address inequalities. I was very happy to see that. Number 2 is the need for education, new models for education and curricula. The third is the way we are spending the European money. And Mr. Sokol actually said that we should have indicators on how to spend European funding for this. It's very important as well to have different type of twinning and teaming projects. And this is very important, especially in Eastern countries, to accept that we need your help in Western countries. And this type of consortium build together with group from Eastern and Western countries, I think it's a way forward. And at the end, I think it's very important to start using in the right way the data related to the cancer. And in this regard, if the European health data space will focus on the data provided by the health systems, I think we'll have a major issue, because the health system like the Romanian ones, we don't have registries for cancer. So actually the cancer patients from Romania will not benefit from the initiatives that will come from the European health data space. So in this regard, I think it's very important to find a way to incentivize citizens, patients or not, to contribute to the European health data space with their own data. And I think this should be as well a way to explore. I'll stop here. Those are the 5 recommendations we have in order to reduce inequalities.
That's great, thank you. We just have a couple minutes left, and I quickly would just want to go around and ask everyone one final question. Stefani, I'll begin with you. If you can make one key recommendation, obviously there's a litany of things. There's, it's a laundry list that's come out of the Beca report. If you could choose just one, what one would you choose to try and implement immediately?
Okay,
you can just choose one. That's all you got. And you've only got 30 seconds, so go.
Yeah, okay. No, I think if I should choose just one, then I think that it's really important to invest a lot in the early detection, because I believe that is really the key factor that can really offer different kind of opportunity and good benefit for people, early detection.
Thank you, Stefani. Mark, same question to you. If you could get one implementation, obviously the Beca report is a huge laundry list. If you had to choose just one and say, okay, we do this first, what is it?
I want to go to basics and say disaggregated data for all of the data sets. So gender, race and ethnicity, and socioeconomic status. You should be able to look at the data via those three lenses so that you can actually then measure the health inequalities and who's missing out.
Thank you. Dr. Pleshtina, from your perspective, if we had one thing to implement, what would you like to see quickly?
I think there is a strong need to consider new funding models, health technology assessment processes that capture both patient and systemic benefits, and appropriate regulatory standards comparable in all European Union. Data, of course, but we need to share data so to have as quick as possible better end results for our patients.
Thank you very much, Dr. Pleshtina. And Marius, last word to you. What do we need to do to quick win?
Cancer literacy for all the stakeholders with a focus on innovation. And
fantastic. Fantastic. It's easy. It's done. Thank you all very much for your contributions. I'd like to thank everyone for attending. I'd like to thank you, our panel, for your excellent participation. And with that, we are just about done. It's the 15th of December. Brussels has a tendency to shut down. So with that, everyone, have a happy holidays and Merry Christmas. And thank you for your participation today. Bye-bye.